these hospitals.
Don't touch the others, just touch this one so that it doesn't go back.
So let me share with you the results from this study about the socio-demographic characteristics. We found that people more than 5 years old were 60.1%. Male were 50.4%. About occupations, those who had other occupations were 53.1%. Some factors were found associated with severe malaria. Patients under 5 years were 8.2 times more likely to have severe malaria compared with those aged 5 or above. Male were found 2.5 times more likely to have severe malaria compared with females. Patients without any health insurance and those who were using community-based health insurance, called MUSA, were more likely to have severe malaria compared with those who had other health insurance like LAMA, MMI, and private health insurance. Farmers were almost 3 times more likely to have severe malaria compared with those who had other occupations. Those for whom it was very difficult to get the health facility were 2.7 times more likely to have severe malaria compared with those for whom it was very easy to get there. So, this study showed a high proportion of severe malaria from about 63.6% among patients under reference to hospitals. A number of factors were found associated with severe malaria in Rusizi district. So there is a need high to strengthen malaria control and prevention interventions among under 5 years children and males. There is a need also of population sensitization toward having health insurance. Capacity building in effective malaria cases management at lower level is also of a high importance, especially in malaria endemic areas. So I would like to acknowledge the following. So thank you for your kind attention.
Okay, thank you very much, Bibiane, for that nice talk. So we will hold the questions till the end. So if you have any questions, just take them and then we'll ask at the very end. So our next speaker is going to be Habimana Metusela. So Metusela is a pharmacist who works at Rinkwavu Hospital. and you're going to talk to us about some rapid diagnostic assessment. So over to you.
Thank you very much. Good afternoon, everyone. My name is Habimana Metsera. It is my pleasure to share with you research finding from the study conducted in the eastern province of Rwanda in Ngoma district. The title of this presentation is entitled Quality Assurance Assessment for Malaria Rapid Diagnostic Test in Ngoma district, eastern province of Rwanda. This is the outline of my presentation. Malaria rapid diagnostic tests are increasingly used in a community by community health workers while diagnosing malaria. However, the diagnostic accuracy of malaria rapid diagnostic test remain unknown. Therefore, we sought to determine the diagnostic accuracy of malaria rapid diagnostic test of those tests performed by community health workers in community. It was a cross-sectional prospective study where community health workers collect a sample of malaria suspected patient and analyze them by using malaria rapid diagnostic test, and community health workers themselves prepare slide for conducting malaria microscopic test at health center by using microscopy as a gold standard test for malaria testing. In total, 420 blood samples were collected. Then it was conducted from 22nd April up to 8th July 2021. It was revealed that the prevalence of malaria by using malaria rapid diagnostic test performed by community health workers was found to be 2.6%, while malaria prevalence by using microscopy, which is a gold standard test, was found to be 1.6. The sensitivity of malaria rapid diagnostic test, which is the ability of those tests to diagnostic collectively the patient who really have the malaria, was found to be 85.7%, while the specificity of those tests was found to be 98.7%. Negative predictive value, which is the probability of being free of malaria where the result is negative, was found to be 99.7%, while positive predictive value, which represent the probability of having malaria when you receive a positive result, was found to be 54.5%. The accuracy of malaria rapid diagnostic test was found to be 98.5%. In order to measure agreement between malaria rapid diagnostic test result with malaria microscopic test result, we performed the kappa test, and its value was found to be 0.642, which means that there is substantial agreement between those test results. Conclusion: the sensitivity of malaria rapid diagnostic test performed by community health workers was found to be below the recommended WHO recommended value for sensitivity, while the specificity of those malaria rapid diagnostic tests performed by community health workers was found to be above WHO recommended value for those tests. Therefore, microscopy is suitable for malaria quality control test as a part of quality assurance for malaria PD diagnostic test result in Ngoma district. And result from this study can be applied to other districts in the eastern province of Rwanda, as they share the same geographical similarities. We acknowledge the following. Thank you.
Thank you so much, Metusela. Next is Olivier Sekuye. He will be telling us about his work on indoor residual spraying uptake and its effect on malaria morbidity in Goma district. Welcome, Olivier.
Thank you very much. Good afternoon once again. I'm going to present my findings about the uptake and effect of indoor residual spraying on malaria morbidity in Ngoma district. Indoor residual spraying consists of applying the insecticide on walls where actual mosquitoes rest. Different studies have indicated that indoor residual spraying has a positive effect on malaria prevention. In Africa, population protected by ILS against malaria have increased since 2005 from 10 million to 124 million to 2013. Other studies have indicated that ILS uptake among households is determined by the level of education, occupation, and the economic status of the household. In Rwanda, since in 2012, we have observed the increase of malaria incidence till 2016. However, a decrease in malaria incidence was observed from 2018 to 2020. Among the control strategies that are implemented in Rwanda to control malaria, it includes long-lasting insecticide-treated nets, case management through home-based management and at the level of health facilities. In addition, we have also indoor residual spraying. In Rwanda, indoor residual spraying started to be implemented in 2007. Currently, 13 districts over 30 have received ILS intervention, and around 4 million of people in Rwanda are currently protected by ILS. Ngoma, as one of districts that had high incidence of malaria in Rwanda, it received 2 rounds of ILS in March 2019 and August 2020. But there was limited data on the effect of ILS in this district. This is the reason why we conducted this study to assess the ILS uptake in Ngoma district and its effect on malaria morbidity in Ngoma. Our study objectives, the main objective was to assess factors associated with ILS uptake and the factors and the effect of ILS intervention on malaria morbidity in Ngoma. Specific objectives were to determine factors associated with ILS uptake among households and to determine monthly incidence rates from January to March in Ngoma district. The third objective was to assess the change in monthly incidence before and after ILS intervention in Ngoma district. That's the map of Ngoma district. It was our study area. Ngoma district is located in Eastern Province and it is surrounded by four districts and Burundi country. This study was designed in two ways. The first way, to respond to our first specific objective, we conducted a cross-sectional household survey by using a multi-stage cluster sampling. Then, to respond to the second and third specific objectives, we used an analysis of secondary data from HMIS among patients diagnosed with malaria in Ngoma district. Our study population, we collected around 9,019 patients diagnosed with malaria during that time. And during the household survey, we visited 636 households where heads of household were interviewed, and households that were not existing during the time of spraying were excluded in the study. The data that we used were extracted from HMIS. Then for the household survey, we administered a well-structured questionnaire to the head of household or a designate of the head of household. Then our data collectors were trained, and we also assigned them their supervisors. The variables that were collected, for data collected from HMIS, the dependent variable was the malaria morbidity rate, while the independent variable was time period before and after the intervention. While for household survey, the dependent variable was the household spray status. The independent variables were the socio-demographic and the characteristics of households. By sampling, we used that formula, and we accounted for a design effect and 10% non-response rate, which gave us a sample size of 636 households. We also selected the 4 sectors in Ngoma district, and in each sector we selected 2 cells. In each cell we also selected 2 villages. Then from those villages selected, we took 40 households that were selected randomly. And the data that were used, we used all data during that period that were entered in HMIS from January 2018 to March 2021. During the analysis, we calculated incidence rates, and also we used an interrupted time series. Then for household survey, we calculated frequencies, and we used data version 15. We obtained the ethical clearance from University of Rwanda, and also we were allowed to conduct the study by Ngoma district, and also confidentiality was ensured. Those are the results. As I said, we visited 636 households, and those are the variables that were collected from the households, and the median age of our head of household was 39. As you can see on this table, it is showing most of cases of malaria in Ngoma district were diagnosed in the community at the rate of 77.9%. That is the trend of malaria incidence from 2018 to 2021. As you can see, it decreased a lot. By comparing before and after the intervention, for the first intervention, there was a sudden drop of 18.8 cases per 100 population, but also incidence continued to decrease. By looking at the second intervention, after the second intervention, there was a drop of 1.5 cases per 100 population. Those are the factors that were identified to be associated with IRS uptake. The one that was significant was being self-employed and having got the source of information about IRS from media, radio, or TV. We were not able to use a control group as a limitation, but also our sample size during household survey was not large enough to identify factors with smaller effects. However, we used data collected from Ngoma district from patient diagnosed with, or data collected from patient diagnosed with malaria in Ngoma district. By concluding, our study findings are shown that the occupation and source of information were associated with IRS uptake, but also the first IRS intervention in the Ngoma district prevented the peak that was expected in June, and the second intervention sustained the malaria morbidity reduction to a very low level. We recommend during planning and implementation of IRS to just focus on occupation and communication channel used to receive information on IRS. And also more studies can be conducted on ILS by using a comparison group, even studies to assess factors with a larger sample size. We acknowledge the following. This is the end of my presentation. Thank you.
Okay. Thank you very much, Olivier, for that talk. So we are going to move on to Noella. Noella does not need an introduction because we met her this morning. But what she's going to talk about today, this afternoon, is the performance of community health workers in malaria case management and associated risk factors. And this is in Rusizi district. Welcome.
Thank you very much. Good afternoon. Are you still interested with malaria? Thank you. I'm going to talk about the performance of community health workers in malaria case management. As Dr. Lina was saying, there is a huge burden caused by malaria, as each year more than 400,000 people die of malaria, a preventable and treatable disease. An estimated 2/3 of deaths among children under the age of 5. And in 2019, new malaria infections were 229 million, and above 400,000 people died of malaria worldwide. African region, with estimated 215 million cases, accounted about 94% of all cases. Rusizi district, as you saw during the presentation, is among the regions with the highest annual incidence. And since 2005, community health workers have been treating pneumonia, diarrhea, and malaria in under 5 children. In 2016, the package was expanded to child over 5 years and adults. So we conducted a study aiming to assess the performance of these community health workers in community malaria case management and associated factors in Rusizi district. We conducted a cross-sectional study in community health workers working as binome for at least 6 months from Rusizi district. We used a pre-tested structured questionnaire developed in a PM4 to collect data, and these data were about socio-demographic, health system, and measure of performance, and the checklist was designed to mark the performance. Each community health worker was asked to perform at least one rapid diagnostic test, and the test was then performed by a lab technician for comparison, and the performance was defined as the ability to correctly diagnose and treat malaria suspects. This performance was categorized as good or poor, and we use logistic regression to determine the factors associated with good performance. Distinguished participants, allow me to present you the findings of our study. About the community health workers' characteristics, of the sample size of 390 community health workers, their mean age was 47, and the standard deviation was 9.8. 58% were female. About 84% had primary education, while 15% had secondary education and upper. And the years of experience, around 50% of them had greater than 10 years of experience in community health workers. With this performance, the general knowledge was categorized as good or poor, and 58% had good general knowledge, while in performing RDT, only 47% performed well these rapid diagnostic tests. In interpreting this RDT, 54% did not interpret well, and 56% of them prescribed well the medicine. The overall performance, as I told you, the performance was defined as the ability to correctly diagnose and treat, and we combined this as in performance in case management, and the overall case management performance was good at 47%. The factors that were associated with good performance, among them we had what we called performance in initial trainings. You know, when these community health workers have what we call validation sessions before starting the activities of treating kind of diseases. And the performance at initial training was also associated with their performance, where those who performed well at the first session were more likely to perform well compared with their colleagues who retook the sessions. And the timely availability of supplies was also associated with their performance, where those who have their supplies available to them are also more likely to perform compared to their colleagues. Another factor that was associated with the good performance of these community health workers is the general knowledge, where those with good general knowledge are more likely to perform well compared to their colleagues with limited knowledge, according to the evaluation we did. And the number of tests performed was also associated with the good performance. As you know, also practice makes perfect. This may also be associated with this. As a conclusion, the performance of these community health workers in Rusizi district is not generally high, and regular trainings and continuous supervision should be provided to these community health workers. The performance of community health workers in initial trainings should be taken into consideration during the validation sessions, and the in-charge should also ensure availability of required supplies and job aids. We acknowledge different partners, and I thank you very much for your kind attention, and I welcome you to the question. Thank you very much.
Thank you so much, Noela. Next, last but not least, is Francois Hakizayezu on assessing treatment outcomes and factors associated with mortality due to malaria in Monini Hospital. Welcome, Francois.
Good afternoon once again. I'm Hakizayezu Francois, currently working in Nyaruguru District, Munini Hospital. And it is a pleasure for me to share with you the findings from the study with the title of Assessing Treatment Outcome and the Factors Associated with Malaria Mortality in Nyaruguru District Hospital within 2016 and 2017. Those are outlined to be covered across this presentation. So as background, in short, malaria, as you know, is caused by Plasmodium species, and the headache, fever, and joint pain and other symptoms are the most likely symptom to appear to someone presenting malaria. So 90% and 91% of cases and deaths respectively were reported in 2016 in the African region. So when you see the factors in general which may be associated with malaria, normally are likely to be environmental and social, depending on every country culture and behavior of their population. In 2016, malaria was the second cause of morbidity in Rwanda with 7.4%, and the sixth cause of mortality. In the same year, it was the most leading cause of death in the hospital, in the Munini Hospital, among inpatients. So this study was aimed in assessing treatment outcome of malaria and the factors which may be associated with its mortality. As you are seeing there, this was a retrospective cross-sectional study, and the working area was Munini Hospital among inpatients admitted in the year, as I said above. We used the secondary data from registers in different services, including internal medicine, pediatry, maternity, and that time we were not having the Department of Emergency. After collection of data and filling the line list, we computed them and analyzed the data using a PM4 in a descriptive and bivariate, but in a logistic regulation, I used Stata software. The study included the whole population. There was no need of calculating the sample as long as our study population was only 401. Those were only the patients who were admitted in that period due to malaria. So we included them, all of them. After the analysis, to tackle on some factors behind the mortality due to malaria, we used the p-values, odd ratio, and a variable which we're having lesser than 0.05 p-value was considered to be significantly associated with malaria death. Let's jump on the result part and start by descriptive analysis in short. Male were less than female. As you are seeing there, female were 237, while male was 164. So after computing, you have seen that 8% of all admitted malaria cases in that period was successfully treated and was not successfully treated and finally died, while 92% was alive. So the most affected age in that period was including from 1 year to 20 years, while the maximum year among our study participants were having 101. So you are seeing that in Nyaruguru, in that period, among those admitted patients, around 93% were having health insurance, while around 4.4% were delaying in consulting health facilities while presenting malaria symptoms. After the computing and logistic regression, as I said in methodology, we have seen that a patient admitted with a disorientation as a symptom related to malaria will having the most chance of dying due to this malaria among our study participants, and the risk of dying was around 1.3 times for the patient with headache if compared with others. Also, the risk of dying was 2.1 times greater than for those who are presenting joint pain if you compare to others presenting other symptoms. Sorry, this is a technology as you are seeing there. So, but I don't know, you can help us. Yeah, I see engineers have helped me to come back. So, as you see, delaying in consulting health facilities was significantly associated with malaria death, and the advanced age was also seen to be associated with malaria death. Lastly, we have seen that for a patient without any health insurance was more likely to suffer from malaria and end by dying. To conclude, let us say that the most affected with malaria was belonging in young age, as I said, between 1 and 20 years old, the most affected and admitted among inpatient. So delaying in consultation was highly associated with malaria death. We suggested in recommendation improving sanitization in the community for the early consultation when someone is having symptoms with suggesting malaria. But also, people are requested to search on time their health assurance so that they could consult on time without delaying, maybe due to the lack of means for having health care at a given health facility of their level. So at the end, we'd like to acknowledge those organizations due to their sincere participation in this work and in our study background. I end by here and thank you for your kind attention. Thank you.
Thank you, Francois. Thank you, all presenters. Any questions, suggestions? No questions? Scientists in the room. Did we do you justice with the data? I'm told there's a question in the middle. Could we have 2 mics? There's another question over here.
Thank you I have 3 questions for 3 presenters. For the first one, you recommend that we have to encourage people to have insurance, and you didn't mention in your presentation if the people without insurance have getting a lot malaria compared to the others. For Noela, also I have a question. You said that, you didn't say that the low level of education of community workers can contribute to the not perform well in treating malaria. And also, I didn't get if the age have an impact on do not perform well when the community workers are treating malaria. So I have that question. And for the last presenter, you conclude that the age category between 1 and 20 is those age category, you combine the category from 1 to 20 years. So I think the interventions are different for that age category. For me, it can be better to say less than 5 years, as we are giving data in the HMIS differently for the people less than 5 years and above 5 years. And also the interventions can be different for those age category. Thank you so much.
Presenters, do you want to go first with the 3 questions?
The question, it was addressed for me, but I don't know if it is allowed to go back on the presentation, but that factors was found associated with severe malaria. If it is allowed to go back on the presentation, they can show us we found it there.
Right. I think we can share the presentation later on if you're confident that it was done. François Noëlla, do you mind addressing your questions?
Thank you very much, Grace, for the question. You asked about the low level of education and the age, if they were associated with the performance of community health workers. Yes, we assessed these variables by the, everything cannot be put on the slides. We only put the variables that were significantly associated with the outcome variable with the performance of community health workers. During our analysis, we didn't find any significant association or any significant difference between the age or the age groups to be associated with the performance. That's why we didn't present it. About the level of education, it was also not associated. Only what we found is that what we assessed as general knowledge, when these community health workers are treating malaria, they use some logbooks. There are things, many things that they are doing, including calculating the age in months, including taking the MIWAC for the children, including there are many things. We assessed those as general knowledge, and we found that those with limited knowledge were likely to not perform well compared with those who had general good knowledge about these things. That's what we found. Thank you.
Thank you, Noëlla. François, 1 minute.
Yes, thank you for the question. You have asked why I tried to use 1 to 20. In my computing, they are computed differently. Below 5, they have their own group, and between 5 and 15, because I know its impact both in treatment and in reporting. But when I was preparing this short document, normally according to my recommendation, you have seen that I recommended to early consult and search for health insurance. For this presentation, my aim was to tackle why and how to intervene. Those young age people normally do not have their full responsibilities. Both for searching for their health insurance, you will see when you are an adolescent in that age, you remain being a part of your family member, and when you suffer from any disease, you are a victim of your family, which didn't search on time the health insurance for you to be treated on time. And also, I wished to early consult, because you may see those are study age or baby age. Both consulting, you may see that they are not having a full responsibility to take a decision of themselves and say that me alone, I'm going to a given health facility for searching for health care. But thank you for the question, because I know in management, clinically, there are differences. This was so grouped to locate it to my final recommendation in brief. Thank you.
Thank you so much. We're going to take the 3 next questions all together, and you try and take notes to be able to remember them. Next, yes?
Thank you. I'm called Miranda Gijimana. My question was also addressed to Francois, but he answered a little bit. I would like to ask him why he didn't consider under 1 year, but I understand that by recommendation he would address it. Also, I want to ask there is someone who says the performance about the community health workers. Most of the time, the community health workers are experiencing the stock out of equipment. How do you measure its performance when they have a stock out? Thank you so much.
I think the second part of the question is addressed to Noela.
To Noela, yes.
Yes, okay. Next.
My question is addressed to Francois. I'd like to know if you ever tested the delaying of consultation and the lack of insurance, as they may both be related. My second question is, where did you consider the first consultation? Was it at the community level or health center or at the Munini Hospital? Thank you.
Thank you so much. Dr. Allen?
Thank you. Thank you. My question goes to Noela thank you for the good presentation. Then I have a question in regard of the tool you have used to evaluate community health workers, and if you can explain well the package you are evaluating, if it's only malaria or not, because if I understood well, you are saying that you are evaluating the MIWAC and other, and also stuff in terms of knowledge of all the big package they are doing. So then we can see if you can split in terms of different variables and try to identify only the malaria package, and also see how you have been comparing community health workers and health providers. Yes, we know they have different backgrounds, and all, so you try to explain us, and we can see if this tool can be, if it was validated, and how this data can be generalized. Thank you.
Thank you. For the interest of time, do you allow me to take one more question? Yes? Okay. We have the gentleman at the back there. And other questions can be discussed with the presenters of the panel. He's over there in the pink shirt.
Thank you very much. After seeing the presentation of Farina, I would like to address my questions about Dr. Aline or BC member in the case of follow-up of malaria. Seeing that more than 50% of community health workers, the performance is low, and seeing that the more cases of malaria are treated at the level of community, don't you have a worry about the resistance of treatment in the future for malaria? Thank you.
As we conclude, maybe Dr. Aline will address that as we wind up. But Noela, over to you, and Francois next to Noela.
Thank you. I'm going to first answer the one who asked about the stock out or the availability of supplies to these community health workers. As you know, these community health workers have like store cards of some medicine and some reagents that they are using in the community. Some of the variables that we were assessing, we used to assess like health system related factors, and these included the supplies availability. While evaluating this, we consulted the stock cards, and we considered the stock out on these stock cards. That's how we measured this stock out of supplies used by the community health workers. Now, coming to what Dr. Lin asked about the package that we were assessing, we were really assessing malaria, and maybe with the time ahead, we can show you how we came up with ranking this performance. We ranked the performance by considering the diagnosis, like this performance of rapid diagnostic tests. We also considered the interpretation and the medicine prescription in we used the logbooks. Now, with this general knowledge, we didn't consider it like marking the performance or saying that this one is performable or not, but we consider this general knowledge as one of the factors that may be associated with this good performance in malaria case management. So how did we do it? We used the checklist, and with this laboratorian, a community health worker took a sample, put the buffer solution and everything that's done by when taking a rapid diagnostic test. The laboratorian was seeing how the community health worker is doing it, and then using the checklist he was marking. If the community health worker performed well the test, and if he interpreted it well and was able to prescribe the medicine according to the test, he was now qualified as one who is performing well. That's why we did it. Now, with these things of MIWAC and WAT, we consider them like assessing the general knowledge in the package of community health workers. I don't know if I explained well to the question that you were asking, Doctor. Thank you.
Maybe you have a side talk with Dr. Lin. She was also asking if those tools were ever validated, but let's go to Francois. You can address that with Dr. Lin aside.
Thank you.
Yeah, thank you for this time again. I received these two questions, one from the gentleman there, and the second one from anyone in this area. So, for the first question, as I have mentioned in my presentation, after the data collection and the computing in the descriptive analysis, have seen that the mean age was 1, and the maximum age was 101. So I think there was no need of including lesser than 1 age, while our study didn't include anyone with the said age. I think it was this was the question. For the second one, as all of you know, when we are carrying out a study, using a secondary data, it is a challenge. So, during this study, I normally use data from registers. So, in register, there is a column where a medical doctor put a summary of anamnesis. In anamnesis, the medical doctor mentioned the number of days with illness before consultation. That number documented in registers are the one we will use to say that is a number of days or a period spent with illness before being admitted in Munin Hospital. Thank you.
Thank you so much, Francois. I hope everybody has been answered. Before I pass on to Dr. Lin, I just wanted to make sure that the data that was presented here and the ratios are not just crude ratios, because we are speaking about policy implications and whatnot. So maybe in the detailed manuscripts or moving forward, show us more on what you adjusted for and what were your crude analysis separately. Dr. Lin, over to you, and please wind the conversation if you can. Thank you, everybody.
Thank you. For the question. This funding is in regard to the performance of community health workers. We are looking to work with Noella and see if these fundings can be validated. And then after we see how if there is any room of correction if these fundings are correct, because there is also CHO who are in charge of supervising, check on regular performance of community health workers on what they are doing, and also we are even now planning to see how those who have an age who is above 50 to be replaced, they do regular performance and see if they perform well, if any need of changes. So it's something which is being done routinely to see how, as we know that 6% are being treated at community, is something which is very important, and we make sure within the program that they are doing a good job and give us accurate fundings, so they prescribe well treatments and also diagnose, so we are preserving all the anti-malaria drug we have in country. Thank you very much.
So, good evening, everyone. There's not so much energy in the room. Good evening once again. We are coming to the end of the sessions for today, so just give me that last piece of energy that you might be having. So, good evening once again. Sorry, I had to do that 3 times. So, we are coming to the end of the day. Just before we wrap up for the day, I would like to invite the audience to a poster viewing session. This poster viewing session is going to happen outside the room. It's going to last for about 45 minutes, so please don't leave before you pass by our poster sessions. Again, I would like to remind our authors to exit and stand by their poster boards, so once the audience is out and they're going to see or view the posters, you are there to give explanations so that we make this, we enrich this poster viewing session. And then, of course, just before we leave, we're also going to have refreshments. So once you're having, or you're going to view your posters, please have a cup of coffee, a cup of tea. We have some cookies outside there, so don't leave before you do that. Of course, then, as an additional announcement, before we close or we wrap up for the day, tomorrow we will start at 7:30. That's when the doors swing open and we start our registration. So for those who can, please, you can come in at that time. We would like to start our plenary at 9 o'clock so that we can keep time. So please just remember that. Then we also encourage people to wear those beautiful blue t-shirts that have been distributed to you. If you can, we would like to see you tomorrow in that beautiful blue t-shirt. We will have a very good afternoon photo session, and it would be nice to have a number of you in those very nice t-shirts that have been given to us. So once again, I would like to thank our guests, our hosts, the organizers, the presenters, and of course, most of all, I would like to thank you for being present with us today. So with that, we would like to wrap it up here, and we will see you tomorrow. Thank you very much.